Hi, good morning, everyone. Good morning, and thank you for joining us for the Winship Grand Rounds this morning. If you're an Emory University or healthcare employee and would like to receive a CME credit hour for attending today, the access code is 872390 and can be found in the chat feature at the bottom of your screen for our virtual attendees. If you have any issues with this webinar or the CME login, please send Cariato an email or drop a note via the chat feature. This morning, we're pleased to welcome my mentor and longtime friend, Dr. John Su. Dr. Su received his bachelor's and medical degree from the University of Miami School of Medicine in Miami, Florida. He completed his internship, residency, and fellowship at Cleveland Clinic from 1990 to 1995 and joined the staff in 1995. He was the residency program director from 1996 to 2002. Dr. Su is currently the chairman of the Department of Radiation Oncology and the associate director of the Gamma Knife Center at the Brain Tumor and Neuro-Oncology Center at Cleveland Clinic. His primary research interests are brain tumors, gamma knife radiosurgery, and innovative radiation modalities. He has participated in numerous in-house pharmaceutical and cooperative group trials. Dr. Su has been an exam writer for the ABR as well as oral board examiner. He serves as a reviewer for many medical journals, and he's a member of various medical societies and very accomplished and highly published. Please welcome Dr. Su today for his talk, Contemporary Management of Brain Metastases.
Thank you, Mohammed, for that long introduction. So thank you. It's always great to see former residents like Mohammed do so well. And he graduated from Cleveland Clinic back in 2011. I'm really proud that he's now a professor of radiation oncology, now the vice chair of education as well. Also want to thank Dr. Jaxie for inviting me, and I had a lovely dinner last night with her and her colleagues. So I'm going to talk about contemporary management of brain metastases. This is a topic that I have seen a lot of patients through my nearly 30-year career in radiation oncology. These are my conflicts of interest. All right. So the objectives of the talk are to provide an overview of the natural history and prognostic factors for patients with brain metastases, review the results of whole brain radiation therapy, stereotactic radiosurgery, surgery, and some of the newer immunotherapy combinations, discuss some of the ongoing and completed studies. There's a number of studies that we'll go through, and discuss the impact of tumor biology and outcomes. So you think about brain metastasis, this is the most common neurologic complication of cancer. Each year in the United States, over 200,000 Americans are diagnosed with this disease. If you think about the breakdown, the majority of patients have lung cancer, about half the cases, followed by breast and renal cell cancer. There's a wide range in terms of the age, but we know there's a lot of prognostic factors, which I'll talk about in a little bit. And the good news is that when you compare the very first patient, and actually when I was a resident back in 1991, the very first patient I saw was a patient with brain metastases. Remember, the senior resident at the time told me, John, don't spend too much time with the patient because you probably only live a couple of months. It actually left a very big impact on me in terms of how to think about cancer patients overall. And today, thanks to a lot of advances in technology, understanding of biology, some of these patients can do quite well for long periods of time. So in terms of factors used to assess patients with brain metastases, there's a number of factors we think about. We think about the number of lesions, size, location, performance status, where the lesion is located. What's becoming more apparent is patients now come to see you with Google on hand, like, hey, I heard about radiosurgery, I heard about immunotherapy, what should I do for treatment of these tumors? Extracranial disease status is also important, and then also the biology as well. So if you look at these two images, the image up on top would be managed differently than the image on the bottom. So let's talk about the first prognostic index, which was really used, is the recursive partitioning analysis from the RTOG. This is based on 3 consecutive brain metastases studies from the radiation therapy oncology group that broke these patients down into class 1, class 2, and class 3 patients. And it's really the 4 factors are based on the age of the patient. If you're 65, you can cut off. You have extracranial disease, absence or presence. You have controlled primary, yes or no, and the KPS as well, whether or not you're functionally independent. So you see for class 1, which represents about 20% of this cohort, median survival is about 7 months overall. you're a class 3 patient, which is KPS of 70, regardless of the other factors, your survival is only 2.3 months. And then the middle group, class 2, was 4.2 months overall. Because control of primary is somewhat subjective, there's another prognostic factor called the graded prognostic assessment, or the GPA, as by Paul Sperduto. This is based on 5 randomized RTOG studies, and really the main difference is rather than having control of primary, it's looking at the number of brain metastases. It's a little more granular overall, 0, 0.5, and 1. So as an example, if you're under the age of 50, you have a KPS of 90 to 100, 1 single brain met, no extrarenal disease, your median survival is 11 months, whereas if you are GPA of 0 to 1, your median survival is only 2.6 months. And a good way of, I tell residents, Cleveland, the way to think about it is to think like a grade point average. If you have a grade point average 3.5 to 4, you're probably going to do pretty well in college. If your grade point average is 0 to 1, you're probably not going to do very well in college. So it's a good way of thinking about the numbers overall. Then the next step was called disease-specific graded prognostic assessment, or DSGPA. So this is based on taking each of the histologies, like non-small cell lung cancer, breast cancer, melanoma, and looking at different factors. So as you can see, just as an example, breast cancer, for instance, the impacted subtypes of luminal B does much better than the luminal A, and you have higher points. So just to give you an idea, a GPA of 3.5 to 4 breast cancer brain metastases, based on this analysis, your survival jumped up to 25 months overall. So you see there's a difference. You take 11 months, now it's 25 months. You take the best cohort of patients with breast cancer metastases. We're now in an era of biology, so now we know that for lung cancer patients that the impact of EGFR and also the ALK rearrangement status is also very important. So here you can see from this model that for the molecular GPA of 3.5 to 4, your survival now jumps up to 4 years overall. So now we've gone from the RTOG, where you think about class 2, which is majority of patients, 4 months overall. You take a very select subset of patients with lung cancer, now your survival is upwards of 4 years on average. Another index that we look at is something called brain metastasis velocity. This is based from the data from Wake Forest University. So this is looking at BMV. So it's looking at the cumulative number of brain metastases since your initial radiosurgery divided by the time in years. So here you can see in the graph here that if your BMV is high, which is, let's say, 13, you can see that your survival is quite low versus if your BMV is less than 4. That's basis of a clinical study that's ongoing through the NRG right now. So you can see the various, and then you can see the incidence of neurologic death as well increases with the greater number of brain metastases since the initial radiosurgery. So as I mentioned, when I first started residency back in 1991, the patient I saw, the senior resident said, "Oh, this patient's going to die in 2 to 3 months. You shouldn't spend much time with the patient." So if you fast forward now, it's a more modern era. Now, are there patients with brain metastases who can live for a longer period of time? So Rupesh Kotecha, who actually is related to Dr. Jagsi, is one of our former residents now at the Miami Cancer Institute, actually looked at our database of several thousand patients. And he asked a very simple question. In our database, are there a subgroup of patients who live 10 or more years? And here you can see that with time, see the number of patients living 1, 2, 5 years, 10 years continues to drop. So you can see in our database, 1.3% of our patients live 10 or more years. And in fact, the longest survivor is still actually alive today, 25 years. Metastatic prostate cancer, surgical removed, radiosurgery, still doing very well. So again, there's this small cohort of patients that can do well for long periods of time. So the disease itself, again, when I was in training, and I think still today, should not be viewed with a nihilistic approach. There are some patients that can do well for periods of time. So you think about the treatment strategies. The treatment strategy has really evolved. So back in the early 1990s, we thought about steroids, whole brain radiation therapy, and surgery. And since the mid-1990s, the era of radiosurgery has really become a standard of care for patients with brain metastases. I was involved with sensitizers in late 1990s, early 2000s. Unfortunately, that was not helpful. The use of chemotherapy has also been explored, and now we're in the era of targeted therapies, which I'll talk about later in my talk. So let's start with whole brain radiation therapy. The first publication was back in 1950 from Dr. Chow, as looking at, if you think about whole brain radiation therapy, a lot of different fractionations have been explored from phase 3 studies in 1970s, 80s, and 1990s, going from 1 fraction, 5 fractions, 10 fractions, hyperfractionation. The bottom line is the median survival is about 4 months overall for this group of patients. So if you look at some of the studies, RTG 9104, Bill Regine was the PI of the study, took patients with multiple brain metastases and asked the question of, does standard fractionation or stellar fractionation make a difference in terms of outcomes of patients? And what it looked at was a mini mental status exam. So up to a score of 30 points. And if you look at the impact of controlled versus uncontrolled brain metastasis, which will be a common theme that you'll hear today, is that if you have controlled brain metastasis, your difference of mini-mal status exam from 2 to 3 months is not much different. But if you look at uncontrolled brain metastasis from 2 to 3 months, you can see there's a big drop from 2 to roughly 6 points on your mini-mal status exam, really indicating that when you have disease in the brain, it's going to have impact on your functional status, your neurologic status. So you think about whole brain radiation therapy, there's different side effects we think about. So short-term alopecia, erythema, fatigue, blocking the ear, some somnolence later on. Longer term, we worry about memory loss, and that's been one of the concerns of any time we deliver whole brain radiation therapy. Some patients, in very rare cases, get radiation necrosis, and in those long-term survivors can get leukoencephalopathy, and here you can see a flare change if someone developed leukoencephalopathy after whole brain radiation therapy. So when we thought initially about brain metastases, our goal was to improve local control and improve survival. Based on this radiation sensitizer study, this is a drug called metaxalone gadolinium. Manesh Mehta was the PI for this study. Really said, well, for brain metastases, it's very hard to move that needle for survival. So we should look at a different surrogate, and the surrogate is neurocognitive outcomes. So for those who are not familiar, these are the 5 domains that was developed as part of this phase 3 radiation sensitizer study. So trail making A and B is actually taking on a sheet of paper A, B, C, D, E, F. So it takes how long it takes you to do that. Trail making B is more executive functions like A, 1, B, 2, C, 3. So it's going to take longer. Hopkins Verbal Learning Test is looking at getting a list of words getting a list of words. So it's 12 words. You have 3 times to get that word, to get that list correct. And most patients, after 3 tries, can get it, because usually what happens is that you start with 12 words. The words you don't remember, you repeat those words the second try. The words you don't remember after the second try, are repeated the third try. And groove pegboard is looking at manual dexterity. So I'm right-handed, I'm faster at moving a pegboard versus my left hand. And finally, a controlled oral word association test is taking a letter and saying as many words as you can and starting with that letter in 60 seconds. So that's what makes up neurocognitive testing. So if you think about patients with brain metastases, this study showed that 90% of patients have impairment of neurocognitive function before the onset of any type of treatment. So I think it's very important to realize that. So, sometimes as radiation oncologists, we have to blame for everything. Well, this shows that without any type of treatment, patients are going to have some type of neurocognitive deficit. We also know that the tumor growth is bad for the brain as well. So if you look at the red bars represent the progression on MRI scan. It shows that if you look at the various domains, you have worsening of these scores when you have progression tumor. On the other hand, when there's actually response to the tumor based on MR scan, you can see that executive motor function as well as visual motor scanning skills actually improve overall, suggesting that if you control the brain, you actually get an improvement of some of these neurocognitive domains. As I mentioned, with whole brain radiation therapy, one of the big concerns has been, well, what's the impact of neurocognitive decline? So now we actually have 2 methods of trying to minimize the effect of whole brain radiation therapy when it comes to neurocognitive decline. So one is pharmacologic, using a drug called memantine. This is a drug used for patients with mild to moderate Alzheimer's disease, based on the RTG 0614 study, randomizing patients between placebo whole brain versus memantine whole brain, starting at a dose of 5 milligrams, going up to 20 milligrams for 6 months. This actually showed that there was improvement in neurocognitive function. And then the RTG 0933 was a phase 3 study looking at the use of hippocampal avoidance whole brain. This is actually a tomotherapy plan showing the avoidance of the hippocampus. You decrease that dose to less than 10 gray, keep your max less than 17 gray. You also have improvement as well. So based on RTG 0614 and based on RTG 0933, the NRG did this study, CC001. This is a phase 3 study this is stratifying patients based on RPA classification, 1, 2, 3. They had prior radiosurgery or surgery to either whole brain plus memantine versus hippocampal avoidance whole brain, 30 gray, 10 fractions of memantine. Primary endpoint was time to neurocognitive failure using Hopkins Verbal Learning Test, controlled oral word association test, and trail making A and B. And so what the study showed was that there was an absolute difference of 10% when you used hippocampal avoidance whole brain versus whole brain radiation therapy. You can see the graph to your right there. Median survival was about 8 months overall. So this represented the new standard of care for patients who had good performance status who underwent whole brain radiation therapy. Building on this, the NRG did this study, CC001, for patients with small cell lung cancer. as we know, the standard approach for patients who have had complete response to limited stage, and for some cases, extensive stage small cell lung cancer, do prophylactic cranial radiation, 25 grade 10 fractions. So this is actually looking at the stage of the patient, the age of the patient, whether or not the patient had mammalian, which was based on the investigator, randomizing between standard of care PCI versus hippocampal avoidance whole brain. Again, looking at neurocognitive decline. There have been two published papers looking at hippocampal avoidance for prophylactic cranial radiation. One is from the Spanish group, the Premier phase 3 study, which did show a decrease in neurocognitive decline with hippocampal avoidance. Another study showed that there was no difference overall. So the jury's still out on whether or not we should consider doing hippocampal avoidance for these group of patients. Let's switch gears to surgery. So surgery has been an important treatment for patients with brain metastases, and I'll talk some about the early data. So with surgery, this is particularly important when you have a patient with unknown diagnosis, has a single brain met, you're trying to figure out what the diagnosis is. Surgery is really the best method to relieve mass effect for patients who are symptomatic or not responding to steroids. The goal is to get complete resection and to avoid any new neurologic deficits. So let's look at some of the historic data. So the first study is from Roy Patchell, 48-patient trial, New England Journal paper back in 1990, randomizing patients with single brain mets to either a biopsy plus whole brain versus resection plus whole brain therapy, and showed improvement in median survival from 15 weeks to 40 weeks. Functional independence is also important. Local control is also improved by using this approach. Nordic was a European study, also showed improvement in median survival functional outcome. The MINT study, which was in Canada, was a negative study. However, it's important to note that this particular study included patients with very low performance status, which is probably the reason why a difference was not shown. So using this as the backbone for surgical trials, Patchell did a second study, which is actually looking at patients with single brain met, looking at observation following resection of a single brain met versus whole brain radiation with whole brain radiation therapy. The dose at this was, rather than using 36 gray and 12 fractions, use a dose of 50.4 gray and 28 fractions. So here you can see that if you look at the various things in terms of recurrence anywhere in the brain, with observation of 70% went down to 18% with the use of whole brain. Local failure was also decreased 46% down to 10%. Neurologic death, which is important, has also decreased from 44% to 14%. There is no difference in survival. However, it's very important to note this study was not powered to show a survival benefit. Again, so this is a good kind of reference, and I let our residents know in Cleveland that these are some good numbers to think about when you think about brain metastases, single brain met, what the impact is of adjuvant therapy or no adjuvant therapy. Just like in radiation, there's been a lot of advances in surgery. So these are just some of the different approaches that neurosurgeons will use today. At Cleveland Clinic, we use a lot more of the laser interstitial thermal therapy for some of our glioma patients, also some of our patients with brain metastases, particularly for those patients who develop radiation necrosis. There's other delivery systems. Some places are looking at focused ultrasound as well. So let's talk about radiosurgery. So radiosurgery, the first unit was the concept was developed in 1952 from Dr. Lars Leksell, a Swedish neurosurgeon, and he really envisioned a technology that allowed for avoiding surgery. And back in the 1940s, the mortality rate of a neurosurgical procedure was upwards of 40%. So he thought of what can we do to try to develop a different non-surgical tool. So he came up with this tool called the Gamma Knife. The first patient was treated in 1968. When Dr. Leksell started Gamma Knife radiosurgery, what he really envisioned was for functional disease and benign tumors and vascular malformation. He did not envision using this for brain metastases. It was actually many years later that individuals started to look at brain metastases. So if you think about radiosurgery, different compared to whole radiation therapy, the goal is by having these multiple converging beams of radiation to give this very high dose of radiation, and by giving this higher dose, perhaps you get better local control, which may translate into better overall survival. And if you think about brain metastases, it's considered an ideal target. So it's radiographically distinct on CT and MR scan. It typically tends to be small at presentation, usually less than 3 centimeters. It pushes the normal tissue away, and because it doesn't invade brain, you can get this high dose gradient overall. So the goal of radiation oncology is really depicted by these curves. Our goal is to improve the therapeutic index. So our goal is to widen that red curve, the complication curve, from the control curve, which is the white curve. And so with radiosurgery, whether you use a Linac-based platform or a Gamma Knife platform, you're able to separate these curves out. So at Cleveland Clinic, we have 2 Gamma Knife units, and actually we're very fortunate. We have 2 Gamma Knife units side by side. We're a very busy Gamma Knife center. Last year, we did about 900 cases overall on 2 Gamma Knife units. We're also a training center as well. So we have individuals from all over the world who come to Cleveland Clinic, neurosurgeons, radiation oncologists, medical physicists, therapists who come to Cleveland to learn how to use the Gamma Knife. And we have actually trained now over 1,000 individuals since we started the program back in 1998. So this actually next week will be our 27th anniversary starting our Gamma Knife program. We started our Model B program, went to Model C, Model 4C, the Perfection, and now we actually have an Icon unit, which is shown here. So the Icon unit, what's different about it compared to the other units, that it has a cone beam CT scan, so you actually have that. Also allows for mask-based treatment using a fiducial on the nose as well, and allows for tracking and gating. We also have the Spree unit. It's actually the first in North America, so it's very similar to the Icon unit. The main difference is that the treatment planning and remote planning skills are a little different. And you can see that there's a console at the machine itself. So we actually have these units side by side. And if you look at our volume, about 70% of our cases are brain metastases, a big majority of what we treat at Cleveland Clinic. Now, aside from Gamma Knife, there's obviously other modalities that are really good as well. You know, CyberKnife, this is an example, the HyperArc plan from UAB using a Linac-based platform. So there's different platforms, and there's really not been shown that any platform is any better. So it depends on what you feel comfortable using. So let's look at some of the data with radiosurgery. So R2G 9508 was a trial of 333 patients with brain metastases from 1 to 3 lesions, less than 4 centimeters, randomized in between whole brain, 37.5 grade, 15 fractions, followed by radiosurgery boost. And the radiosurgery boost is depend on the diameter of the tumor. So it's less than 2 centimeters, 24 gray, 2.1 to 3, 18 gray, 3.1 to 4, 15 gray. And here you can see that local control is improved, the addition of radiosurgery to whole brain, 82% versus 71%. KPS being stabilized, and steroid use was also better. And in terms of survival, the only group that actually has survival benefit was patients with a single brain met. It went from 4.9 months to 6.5 months. The Japanese Radiosurgery Oncology Group did a trial looking at radiosurgery versus radiosurgery plus whole brain radiation therapy for patients with 1 to 4 brain mets. This is a smaller study of a little over 100 patients overall. And here you can see that with radiosurgery alone, your local control is about 73%. The addition of radiosurgery and whole brain, it went up to 89%. Distant brain failure, as expected, was higher when you omitted whole brain radiation therapy. So this is a study that really kind of changed how we thought about brain metastasis and what our primary endpoint is. So rather than looking at local control, this is looking at neurocognitive function based on the radiation sensitizer study I presented. So this is a study led by Eric Chang, who's at MD Anderson. Small study. This is closed early just because of the early interim results, but comparing patients with 1 to 3 brain mets with radiosurgery alone versus radiosurgery plus whole brain radiation therapy. So if you look at the neurocognitive decline, it went from 52% with surgery whole brain down to 24% when you did radiosurgery alone. So as a result, the argument was made that this should perhaps become the new standard of care for patients with 1 to 3 brain metastases. The ERTC did a much larger study, actually did not look at neurocognitive outcome, but looked at the deterioration of WHO performance as greater than 2. So this actually randomized patients between surgery and radiosurgery, either observation or whole brain radiation therapy. And what it showed was that there was no difference, the median time to deterioration of WHO greater than 2 was no different with the addition of whole brain to either surgery or radiosurgery. Median survival was not any different. You can see that the local failure and also distant brain failure is higher if you did not use whole brain radiation therapy, and also showed, similar to the Patchell study, that when you omitted whole brain radiation therapy, the risk of intracranial death also significantly increases. Well, here you can see in this study went up to 44% from 28% overall. NCCTG was an intergroup study, a bigger cohort study from the Eric Chang study from MD Anderson, looking at radiosurgery alone versus radiosurgery plus whole brain radiation therapy. And this is a study which really started to change how I counsel patients in terms of the side effects related to radiosurgery. So here you can see that the cognitive progression at 3 months was 63.5% with radiosurgery alone. Okay. So so in my mind, that was actually quite high, right? Radiosurgery plus whole brain was even higher, 91.7% overall. You can see in terms of brain control, whole brain plus radiosurgery did provide better local control. It went from around 10% up to about 50% overall. But based on this, when the study came out, I told every patient that it's very likely that you're going to have some decrease in some neurocognitive domain, and then you have to kind of explain what that means overall. And again, this is really based on going through these factors. for some patients, when you have this decline, it's really not noticeable to them or their families. So how meaningful it is, it's hard to determine at times. N107C was actually looking at patients with resected brain metastases. Could you, was it whole brain still the standard of care? Could you do radiosurgery to the resection cavity? These are patients with 1 to 4 brain metastases stratified as shown here, using 60 as a cutoff. And again, this study showed a significant, but in my mind, a pretty minimal difference in terms of cognitive-free survival. It went from 3.1 months with whole brain, with radiosurgery went to 3.7 months. However, you can see the p-value is highly significant. And then in terms of overall survival, you can see that, again, these selected patients, the survival continues to climb. It's now about 1 year for these group of patients. Now, if you look at the results here, again, depending on which side, if you look at the glass half empty or half full, you can see that with radiosurgery alone, the overall control rate is actually not very good at 12 months. For this particular phase 3 study, there's only 32.3%. With whole brain, there's about 70% overall. Surgical bed control for the resection of the cavity, you can see with radiosurgery, it's only 55%, with whole brain, 78%. So again, if you look at the data and you look at control overall of the brain, and you look at local control, you're still like, you kind of scratch your head like, wow, whole brain is still a lot better than radiosurgery if you look at these things. But in terms of cognitive decline, radiosurgery still comes up on top. Now, if you look at the secondary analysis, this is done by Josh Palmer at Ohio State of the N107C study, looked at patients who were survived for more than a year, and looked at cognitive decline again. With radiosurgery, at less cognitive decline compared to whole brain radiation therapy. Then you looked at those patients that had more than 2 standard deviation of change, decline of whole brain versus radiosurgery. They showed that in terms of quality of life, emotional function, functional well-being, there's clearly a benefit for radiosurgery versus the whole brain treatment. But again, you can see this common theme that with radiosurgery alone, the total intracranial control was 41% versus 81% with whole brain. MD Anderson did a phase 3 study, led by Anita Mahajan when she was there, looking at post-op radiosurgery versus observation for patients with completely resected brain metastases. The 132 patients were randomized. This is looked, and you can see the eligibility criteria there, gross total resection of these brain metastases. Primary endpoint is local recurrence from a blinded neuroradiologist. So what this study showed was, so the blue line represents radiosurgery. Freedom from local recurrence was 43%. If you did not do radiosurgery after resection of brain met, you can see the failure was 72% overall, highly significant. In terms of overall survival, again, common theme that you see here, no difference in overall survival. Now, if you take a cohort of patients with smaller brain metastases, you see that you can actually achieve pretty good local control with surgery alone, but once it's more than 2.5 centimeters, you can see the local control drops off quite quickly overall. And then you can see here that in terms of overall survival for this, again, select group of patients, survival is now up to 17 months. Given the concern of whole brain radiation therapy, the effects of neurocognitive decline, and then we know is this ongoing debate of should you use preoperative radiosurgery, giving a dose about 15 gray, or should you use postoperative radiosurgery because it did, the diagnosis, you have, let's say, 2 millimeter margin around it. So let's look at some of the data behind this. So one of the concerns when you do postoperative radiosurgery, and I don't know what your practice pattern here is at Emory, is that if I draw out a post-op cavity, if I have Muhammad draw out a post-op cavity, we're probably going to have some differences of what we consider the cavity. And then that's one of the reasons why at Stanford and other places, and for our studies, we give a 2 millimeter margin around it. So this is a consensus of 10 radiation oncologists and neurosurgeons, quote, experts, asking them to contour out the resection cavity. And here you can see that in terms of sensitivity and specificity, you can see the specificity is quite good, but the sensitivity in some of these test cases was actually not so good. You can see it's 71, 74, 75 overall. And if you look at what was wrong, part of the dura, part of the bone flap, you can see it varied quite a bit. And in some cases, the experts recommend you give a 5 to even 10 millimeter margin, which I'd argue once you start giving a centimeter margin, is a truly radiosurgery to the brain. Because of this margin status, one of the concerns when you do postoperative radiosurgery is that your risk of leptomeningeal disease, particularly nodular leptomeningeal disease, goes up. And here you can see various studies. And you can see the range of leptomeningeal disease goes from about 10% overall upwards of 30% overall. We also know that patients with leptomeningeal disease there's some groups of patients that have higher propensity to develop leptomeningeal disease, particularly those that have lesions in the posterior fossa, those that have breast and colorectal primaries. And here you can see in this study from Stanford that for breast cancer patients, your risk of LMD after post-op radiosurgery was 28% at 2 years. So here's an example of a patient that I treated who unfortunately developed left-meningeal disease and unfortunately succumbed to disease soon afterwards. So if you look at some of the risk factors, how the surgical resection is done is a piecemeal versus more of an en bloc resection, breast primary posterior fossa location. There's multiple lesions overall, and also if it's hemorrhagic as well. So, and one of the other things as well is that in terms of left meningeal disease, there's just some data of what is truly left meningeal disease, and we know there's the classic left meningeal disease you think about when there's the folia, the nerves itself are coated. Then you have more the nodular left meningeal disease, which is this is kind of more nodular. And we know the nodular patients actually do better overall. So there's more research that needs to be done in terms of how we think about LMD. How about a multi-institutional retrospective review of pre-op versus post-operative radiosurgery? This is led by the group in Charlotte, North Carolina, looking at pre-operative radiosurgery. The median dose is about 15 gray overall. Post-op was 18 gray. And here you can see the median trial about 2 years that the risk of LMD was less with pre-op versus post-op. And the 2-year radiation necrosis rate was also less, 16%, about 5%. No difference in local control. If you look at preoperative radiosurgery versus post-op whole brain radiation therapy, again, from the group in Charlotte, North Carolina, you can see that if you look at the local recurrence rate at 2 years, the distant brain recurrence rate, the risk of left meningeal disease, there's no difference between whole brain versus preoperative radiosurgery for this group of patients, suggesting that pre-op may be better than post-op. There are several ongoing studies right now from Mayo Clinic as well as MD Anderson. Also, the NRG has a study, BN012. They're looking at different endpoints, whether or not it's left meningeal disease, symptomatic disease, local failure, and they're looking at is pre-op better, same, worse than post-op radiosurgery. So we'll be anxiously awaiting what these results show. In terms of the post-op cavity, there's been interest in doing fractionated radiation therapy. This is the Alliance study, taking patients, as shown there was stratification, looking at 12 to 20 gray in one fraction. And when you think about post-op radiosurgery, some places will use the volume of disease rather than the actual diameter in terms of how to determine dosing. And looking at 27 gray, 3 fractions, or 30 gray, and 5 fractions for these group of patients. How about for these larger lesions? We know for patients with lesions greater than 2 centimeters, and when we looked at our Cleveland Clinic results, the risk of failure was upwards of 50% for lesions 2 and greater than 3 centimeters overall. So there's been interest in doing fractionated radiosurgery for these group of patients. So this is a study from Rome, looking at patients with tumors greater than 2 centimeters in diameter, looking at a cohort of patients 15, 18 gray in 1 fraction versus radiosurgery 27 gray in 3 fractions. And you can see that for this study, the fractionated group did better. The local control went from 71% up to 91% overall. And also the risk of radiation necrosis is also less as well when you did the fractionated approach versus the single approach. In Cleveland, our approach has been based on what the Japanese group has been doing for a while. It's actually called stage radiosurgery. So really looking at kind of the timing. So this is a paper. We've done actually many more patients since this initial paper from 2017. But for patients with tumors 2 to 3 centimeters, we give a dose of 18 gray. We wait a month, and then there's usually some tumor shrinkage, and we give 12 gray. And for those tumors that are 3 to 4 centimeters, we give 15 gray. We wait a month and give another 15 gray. And by doing this approach, our local control rates were about 90% overall. Our adverse events of any of it was 11%, and overall survival is 50%. So this is the approach. And here's just a case of a patient with a posterior fossa tumor cerebellum. You can see that the first lesion, first stage at A. 1 month later, it shrunk to B, and then we treated again with radiosurgery. It shrunk to C, and then you can see the subsequent image D. So this is the ideal kind of approach that we'd like to see. And our hope is by treating a smaller volume, we will decrease the risk of necrosis and other side effects. So there's a proposed study, BN013. So this is actually looking at this concept of stage versus fraction radiosurgery, looking at radiosurgery. You can see the arms there versus fraction radiosurgery, either 3 fractions, 30 gray, 27 fractions. Primary endpoint is to see whether or not fraction radiosurgery gives better local control versus single fraction radiosurgery. So you can see the end of all the various secondary endpoints as well. How about the number of lesions? So historically, we thought about 1 to 4 brain mets should be the limit of number of lesions. We now know that in Cleveland, for instance, we commonly will treat patients upwards of 10 lesions overall. And this is based on, here's some initial studies from Japan looking at patients with 1, 2 to 4, 5 to 10. You can see there's really not much difference between 2 to 4 versus 5 to 10 in terms of overall survival for this group of patients. MD Anderson did a study of radiosurgery versus whole brain radiation therapy. The study actually was terminated early based on the results of the CC001 study of whole brain versus mantine. But here you can see primary endpoints memory at 4 months overall. And here you can see, in terms of local control, really no difference in radiosurgery of whole brain. Distant brain control, there was no difference as well, which is one of the concerns by doing radiosurgery alone. And then in terms of, but one of the big advantages of doing radiosurgery rather than whole brain is that you can start your systemic therapy, immunotherapy much faster overall. And your grade 3 toxicities, as expected, were less with radiosurgery versus whole brain. Based on the brain metastasis velocity, or BMV, looking at for patients with 4 to 13 or greater than 13, looking at the results of whole brain versus memantine versus radiosurgery or fraction radiosurgery. This is an ongoing study. The study, unfortunately, is not accruing very well, but hopefully will give us a better understanding of whether or not this brain metastasis velocity gives us a better idea of how we should treat these group of patients. And these are some of the various ongoing studies. And you can see some of these trials now are enrolling patients with 20 lesions overall right now. And you see the various endpoints. Small cell lung cancer is an area we did not really think about radiosurgery, but we know from the FIRE study that radiosurgery can be used for selected groups of patients with respectable survivals, about 8 months overall. And meta-analysis has also shown some improvement, reasonable median survival as well as local control. NRG has an ongoing study right now looking at radiosurgery versus hippocampal avoidance plus memantine for patients with 10 or fewer lesions from small cell lung cancer. Radiation necrosis is a potential complication after radiosurgery, so this is what you don't want to see after radiosurgery. The diagnosis can become very tricky overall. And there's a lot of different factors that we think about in terms of radiation necrosis: dose, location, prior therapy, how your planning was done, et cetera. And so as a result, and we also know biology is also very important as well. So this is some work from one of our former medical students who's actually attending now at Cleveland, looking at the impact of biology. So here you can see that HER2, BRAF mutational status, ALK status, EGFR status actually had a higher risk of radiation necrosis versus those that did not have those markers. This is a study from Martin Tom, actually one of our former residents now at MD Anderson, looking at flucycline PET CT to see if this could actually help distinguish radiation necrosis for these group of patients. Here you kind of see the study design that was used for this group of patients. And what the study shows, if you look at SUV max and you look at SUV mean, there was a difference between those patients who had radiation necrosis versus those patients who had recurrent tumor. And as a result, Sam Chow was one of my colleagues, and actually Mohammed knows him very well. There's a study that was done, he's the lead coordinator for the study, looking at use of flucycline PET, determines the difference in radiation necrosis versus brain metastasis. The study is closed, and hopefully in the very near future, it'll be presented at a national meeting in terms of what the results showed in terms of when that provided better predictive value versus the other more traditional approaches of MRI. And because of the imaging biomarkers, there's actually now interest actually using flucycline PET as a biomarker to actually help determine when you should do additional radiation treatment. So this is a study from Miami Cancer Institute looking at flucycline PET. You can see at various time points and then using radiosurgery as part of a staged approach overall. So switching gears to molecular markers. So for non-small cell lung cancer, as you know, there's all these molecular markers that we think about right now in terms of mutational status. And there's all these various targeted therapies that we think about for lung cancer as well. What we do know is that for patients who have EGFR wild type versus mutated tumors, we know that those that have mutated tumors respond better to radiosurgery versus those that do not. Here's just an example of a patient with an EGFR mutated tumor who actually had good response. We also know from data from MD Anderson that when you have the use of erlotinib with whole brain, you can see and they're mutated or not mutated, there's an impact in terms of the survival for these patients. And building on that, Yale looked at their results as well with other institutions. Again, you can see that for patients who have ALK-rearranged tumors, their survivals, was upwards of 4 years overall. And again, the other thing that's also interesting to note is when you think about the GPA, we think about number of events 1, 2 to 3, 4 or more. Well, half of patients with ALK-rearranged tumors actually have 4 or more brain mets. So for these subset of patients, maybe the number of lesions is less important overall. You look at pooled analyses again, you see this trend of when you do upfront radiosurgery with an EGFR TKI, you get better outcomes than you do if you just do upfront whole brain or just do radiosurgery alone. If you look at the Cleveland Clinic experience, it really mirrors what others have shown is that, for the ALK-rearranged tumors, survivals are about 4 years overall. If you have EGFR mutated tumors, your survival is about 2 years overall. As I pointed out earlier, rearranged tumors have a higher risk of radiation necrosis for reasons we don't quite understand. And also the majority of these tumors also, patients have 4 or more lesions. Immunotherapy has really been really dramatic in terms of outcomes for patients with melanoma. There's lots of different monoclonal antibodies, inhibitors, mechanisms that we think about overall. And if you think about melanoma patients, we know those patients have BRAF mutated tumors. They respond better to radiosurgery, and then some subset of patients actually do better in terms of survival as well. And that's why for some patients who have multiple lesions, we actually have BRAF mutations. Some of these patients will actually go with medical therapy first rather than doing some type of radiosurgery approach for these group of patients. In terms of the timing of when you should use a BRAF or MEK inhibitor, it's all over the board. Here you can see this is from the ECOG group looking at, saying you should hold it for radiosurgery 3 days. If you do radiosurgery, hold it for a day. In Cleveland, we typically will do the inhibitors and the immunotherapy pretty close to each other, so we really don't have an exact timescale that we use. I mean, that's a subject of debate overall, but that's kind of our approach in Cleveland. This is just a large systematic review and meta-analysis of just various groups. So you can, again, see that when you do dual therapy with the radiosurgery and with these medical therapies, you get improved local control, as you see by these hazard ratios here. There is, however, a risk of intracranial hemorrhage. We know melanoma patients have a higher risk of hemorrhage to begin with, and by doing these BRAF inhibitors, you actually increase that for some groups of patients. Switching gears to breast cancer patients. So for breast cancer, particularly those patients, different biologies, some of these patients can have brain metastases, which can be quite devastating overall. And we know the patient with HER2 status actually has greater incidence of brain metastases. And if you look at our results overall in terms of local failure, what's interesting is the HER2 status patients actually live longer, but in our study showed that actually they had a greater risk for local failure, some of which could be salvaged with drug therapy, surgery, other types of approaches overall. And here you can also see the impact of using a TKI inhibitor if you have a HER2 or you don't have HER2 disease in terms of local failure as well. RTG finished up its trial, RTG-1119, looking at the results of lapatinib for HER2 positive patients, looking at whole brain or radiosurgery versus radiosurgery plus lapatinib. Unfortunately, this study showed there was really no difference in complete response using lapatinib with either radiosurgery or whole brain. And just to finish up here, just some of the trials. So there's phase 1 studies looking at osimertinib, TKI. So this is patients with 1 to 10 brain metastases, looking at osimertinib before radiosurgery, because it's kind of a dose escalation study or dose de-escalation depending on toxicity with osimertinib. This is looking at olaparib. This is a DNA damage response inhibitor, patients with breast cancer. Again, looking at administration of drug up front, followed by radiosurgery, and then doing more adjuvant therapy to see again what the results are. Tumor treating fields. So this is something that we use for patients with glioblastoma patients based on the results of EF-14 study. So it's actually being explored now for patients with brain metastases. This is for patients with 1 to 10 brain mets, looking at radiosurgery, followed by tumor treating fields. These are the caps. And for those who are familiar, you want to have this cap on for about 18 hours to really have optimal results. So we'll see what this, and it's really at first intracranial progression. So in summary, the optimal treatment for brain metastases is evolving, controversial. So I'm a big proponent of multidisciplinary care. It's one of the reasons why we have tumor boards actually every Monday and Thursday from 4 to 5:30. And also, we're also in constant contact with neurosurgeons, medical oncologists in terms of how to optimize care for these patients. The therapeutic armamentarium has clearly advanced through the years, whole brain, surgery, radiosurgery. We now have targeted therapy, immunotherapy. So we're trying to figure out what is the best sequence, what's the best way of combining these various agents overall. Biology clearly is important in terms of how we think about these tumors. And in the future, we really need to think about how biology impacts necrosis, toxicity, control, survival as well. And I'm a very big proponent of clinical studies. That's really how we make advances. Through my career, I've been a big proponent of supporting the RTG as well as the NRG studies. That's really how you make a difference. I think many times we think we know the answer, but phase 3 studies can be very humbling at times and show that we really don't know the answer. This is a picture of our cancer center. Mohammed, I don't think you've seen our new cancer center since you finished in 2011. So it's a 6-story building. It's all glass on the north and south side. They let natural light in. And then our radiation department is actually in the lower level there, where you see that glass opening there, just to let some natural light into the lower department. We have 6 Linacs, 2 Gamma knives, 2 CT stims, hypothermia, and at some point we're hoping to expand for a bigger footprint for other technologies. And just a plug, since the Cleveland Clinic is actually sponsoring the ISRS, or the International Stereotactic Radiosurgery Society meeting in New York City from May 12th to 15th. Any residents or any faculty who are interested, we're hoping to have about 1,000 people attend this. This is actually the first time the ISRS meeting has been in North America since San Francisco, which is in 2007. And thank you very much for your attention. I'm happy to take any questions.
Thank you, Dr. Su, for a wonderful talk. If you have any questions, please use the Q&A feature located at the bottom of your screen. While we wait on questions, I wanted to mention that the next week we're going to have Kimberly Kersing talking about medical cannabis, the Georgia law and beyond. So it's also online too. But without much further ado, if you have any questions, feel free to ask Dr. Su.
Yes.
Thank you for a wonderful talk, Dr. Seth. I just had a couple of questions. One is, what is the benefit of doing pre-op SRS when those lesions could be treated definitively with SRS? And the second is more based on, there was an article a couple months ago about the combination of ADCs with SRS for brain mets in breast cancer patients. And there was like a 50% rate of radionecrosis. And I wondered if you had thoughts on that and just the biology behind radionecrosis. And I have actually a third question. The third question is in terms of timing, because I think about this. When we go to our med-oncs and say there's a new drug that's come out in your treatment of whatever disease it is, how long do you want to hold it? Do you want to do it concurrently? What is your thought process in letting that go and keep going with the systemic therapy, or holding it, and how much time would you hold it for? Because I don't think there's a whole lot of great data, because we have so many new systemic therapies coming out, and I worry about radiosensitization with those new drugs.
Sure. All right, you're testing my neurocognitive abilities here, so let's see if I remember all the questions here. So, all right, so in terms of benefit of pre-op radiosurgery, so we really use pre-op radiosurgery for these larger lesions that are symptomatic, where we feel that the control rates with radiosurgery are not going to be very good, so that's why we offer the pre-op. In our approach, we actually have a phase 2 study led by Aaron Murphy. We're actually looking at dose escalation for those patients to hopefully get better control. And actually, if you look at our initial results for dose escalation cohort, of the 33 patients enrolled, we only had 1 patient who failed with that approach. So that's number one. So in terms of ADC and sensitizing, I'm going to kind of put that together. So that's concerning, right? Radiation necrosis, they mentioned earlier in my talk, is first of all difficult to diagnose at times, right? So there's, I don't know how things are at Emory, but look at an image like, I think it's recurrent tumor. Someone else will say, well, I think it's radiation necrosis. And then there's this debate of, do we biopsy it? Do we use boswellia? Do we do vitamin D, Trental? I mean, there's all these approaches. Do we do Avastin? So we have to have that conundrum of what to do for those groups of patients. But certainly, from that study, I would be very cautious about combining that with radiosurgery. So I think that's, and radiation necrosis can also be very problematic, as probably many of you know. Radiation necrosis is not something to take lightly. And so we really try to minimize our risk of radiation necrosis whenever possible, just because sometimes, again, it's hard to diagnose, and B, it's also very hard to treat at times. When it becomes symptomatic, our neurosurgeons will, which sounds counterintuitive, will do laser interstitial thermal therapy, where they actually heat up the tumor. The thinking is that it actually changes some of the biology, some of the inflammatory responses around the tumor, so that may help as well. Now, in terms of the question of timing, for breast cancer, and breast cancer I think is great. So first of all, breast cancer patients with brain mets live a long time, right? They tend to be younger as well. They're very functional. So if we do a bad job in the brain, it can be very devastating in terms of quality of life, also survival as well. So for those group of patients, when combining drug therapy and radiosurgery, our approach has always been to be cautious. Anytime we're using a new agent, I will actually sometimes will call down and say, if you're doing something, you're using a drug I'm not very familiar with. Do you know if there's any data? And many times I'll say, oh, I don't know if there's any data as well. But our philosophy, again, rightly or wrongly, is it's very important to control the brain. So we proactively control the brain quickly. And in terms of systemic therapy, we'll follow up soon afterwards. And sometimes, some places will use the systemic therapy up front, followed by using treating the brain. But our approach has typically been to treat the brain lesion first, followed up with systemic therapy soon afterwards. If they do develop complications, we deal with those complications. Like if they develop radiation necrosis, for instance, we typically will start them on steroids first. If steroids doesn't work, we typically, again, depending on their situation, we will consider Avastin or doing laser interstitial thermal therapy.
Yeah. That was a wonderful presentation, review of this. I'm just wondering, so you kind of showed your results of the staged approach. What is the niche for where you use that? Because if it's really large, you might get pre-op and then operate. If it's smaller, you think your local control is good. Sort of what's been your criteria at Cleveland Clinic?
So I would say that for every 10 patients we see with a larger lesion, the majority of patients will get the staged approach, and then probably of the 10, maybe 1 or 2 will get pre-operative surgery. So it's a minority that we do the pre-operative surgery, and on occasion we sometimes will do post-operative surgery because the patient has a large lesion, they're symptomatic, not responding to steroids. Everyone's concerned. They'll go ahead, they're in the ICU, they'll go ahead and resect the lesion first and do post-op. Now, as I mentioned, with post-operative surgery, the concern is LMD, right, and also radiation necrosis risk. So that's something always to keep in mind when you're doing that approach.
How far would you go with the staged approach? I mean, what's your size?
Yeah. So we typically will reserve it up to 4 centimeters. Have we done 5 centimeters? Yes. Have we done 6 centimeters on occasion? Yes, but it's rare. It has to be the right patient. We feel that the patient's not going to get in trouble with swelling and other issues.
What's your, you may have presented, I may have missed it, but what's your reported necrosis rate with the staged approach?
Yeah, so stage approach, it's under 10% by doing it. Now, again, when we talk about radiation necrosis diagnosis, again, it's really the gold standard, as you know, is biopsy. So, we say it's a little under 10%, but it could be a little more, it could be less than that, it could be even more than that. So, because sometimes, as you know, we'll overlay what we treated. The tumor is bigger, so, it's radiation necrosis. Well, we don't know. It could be recurrent tumor for all we know. Yes.
Yeah, very nice talk. I had a question about the imaging. I think you touched on this in one of your slides, but what is the current status of that imaging? Does it influence your target design over the MR? And then what's your preferred radius tracer?
Yeah. So in terms of, our first imaging is with MRI, and then with all our MRIs, we actually get a cerebral blood volume as well. So that's kind of our first standard in terms of determining if there's blood flow to the tumor, we consider it a recurrent tumor. If there's not blood flow, consider it radiation necrosis. If that's equivocal, we will then sometimes use a PET MR to figure out if there's, again, if it's hot on PET or not. And we don't use spectroscopy here. With spectroscopy, you see a lactate peak if it's radiation necrosis. We don't use that. But when there's concern about or uncertainty about the diagnosis, we'll actually do the biopsy. The nurse will do the biopsy, and if it's necrosis, they do LIT. If it's not necrosis, they'll go ahead and resect that particular tumor. Yes.
Great talk. Just going back to the pre-op SRS for the large mets, one of the challenges that we face is that for these truly large mets with intracranial effects and edema, the surgeons are wanting to almost, emergently take them to surgery. And in the published series at Levine and also by Josh Palmer, they seem to have treated small to medium-sized tumors. In your practice, when you are actually treating the large tumors with pre-op SRS, how quickly are you able to plan the radiosurgery, and how many days do you wait?
Sure. So that's been one of the challenges of trying to operationalize a preoperative radiosurgery program, is to do the radiosurgery and then to do the surgery soon afterwards. I'm very fortunate to work with a number of neurosurgeons who really think that, for these patients, preoperative radiosurgery is the best option. So just to give you an idea, this is pretty classic. Saturday, get a call. The on-call person, hey, we've got a patient with a large brain met. We need someone to see the patient. So, the on-call person sees the patient. Typically on Monday, the CNS service will staff that person. The neurosurgeon will say, let's do gamma knife tomorrow, just Tuesday, and we'll resect it Wednesday, Thursday, or Friday. So, and we actually now have the system down where the turnover is very quick right now. Now, initially, were there challenges? Yes, because you've got to coordinate, the radiosurgery, you got to coordinate the surgery. But, our philosophy is that if that's what the patient needs, we'll do things to make that happen.
So Dr. Wang, I think it's a similar question to what Jim was asking. Like, what about for symptomatic patients? Do you do something similar? You try to pre-operate, even if they're symptomatic, or do you just automatically go to surgery right away if they're symptomatic?
So I think it depends on the threshold of neurosurgeon in terms of whether, they decide that surgery can be done or they can alleviate the symptoms with steroids first and do preoperative radiosurgery. So, but if you think about it, if you're going to do the pre-op radiosurgery, it can be done safely, and you're going to do surgery the next day. There's really not much of a time delay in doing that treatment approach.
And there's one other question online, which is related to another question, similar question, two questions I've gotten. One is, number one, what are your thoughts about frame versus mask-based SRS? Any difference in outcome? And if not, how do you select the differences?
Sure.
Like which patient gets
Sure.
what?
So, historically, the radiosurgery program, at least when you use Gamma Knife, has been frame-based treatment. And now with our Icon and Esprit unit, we actually have the option to do mask-based treatments as well. So when I present the options, the first question I ask the patient, are you claustrophobic? So if they're claustrophobic, the mask is not going to work. So that's one way of kind of determining. The other thing is in terms of mask versus frame, if the patient has, if we're doing like a trigeminal neuralgia case or AVM case, we tend to use a frame because that's kind of been our historic standard. Now, there are places that use mask-based treatments for functional disorders. That's really not been our approach overall. Now, when it comes to using mask versus frame for brain metastases, some of that's also neurosurgical preference as well. So that kind of plays into it. So I feel comfortable with either. The one thing about a mask-based treatment with the Gamma Knife is that the elective recommends a threshold of 1.5 millimeter deviation. We put our threshold at 1 millimeter. Right? So there are some patients when it's, and typically with a mask-based treatment, it's hard to be under a mask for over an hour. So that also plays into it as well. So sometimes if the patient has, let's say, 15 lesions, we may try to treat 7 lesions over like 60, 70 minutes of the mask, and then later that week treat the other lesions with the mask-based treatment because it's hard to do all that together. Now, we've also had some mask-based treatments, and I'm sure this has happened to Emory as well, where the treatment's supposed to be 30 minutes and ends up being 2 hours, right? Because tolerance and other issues as well. So it's important that for the mask-based treatment, you get the right patient. And some patients, quite frankly, don't like to have the frame up, right? And so then because of that, they switch to the mask. So it's a combination of patient as well as physician factors we consider.
Any other questions? I have one question I would like to ask. Are you seeing any reductions in the number of brain metastases as a function of dual checkpoint inhibitors and these other ERAS inhibitors, other drugs that are actually impacting the brain incidence of developed brain metastases, and the metastases that are there are actually being controlled? Do you see the overall change in the patient volume and the brain metastases overall?
Yeah, so that's a really good question, Mom. So I would say that, for our melanoma group, the tendency now is to do drug therapy first, and if it doesn't work, they'll refer the patient for radiosurgery. So I say for melanoma, I think the number of cases we get are probably less than before. But I think we've made up for it by just referrals from the outside centers overall. So as I said, if you look at our Gamma Knife numbers, it continues to increase, and we are judicious about how we use the Gamma Knife, which is we don't look for everybody. We want to be judicious about when we use it. So I would say in the future, as drug therapies continue to get better, there's a chance that we may see less referrals for radiosurgery. Now, there's different philosophies, and my philosophy is more, if you have brain mets, it's better to control it upfront rather than, so we tend to do a lot more combination of drug therapy and radiosurgery, whereas there are some centers, I don't know what Emory's approach is, where it may do the medical therapy upfront and then do radiosurgery as a salvage, but we tend to do it upfront together.
Thank you. Any other questions? All right, let's give everyone, Dr. Sue, a round of applause for his wonderful lecture. Thank you, Dr. Sue. Very appreciate it. So once again, as we adjourn, I just want to remind everyone the next week's grand round lectures will be on medical cannabis, the Georgia Law and Beyond by Dr. Kirstein. Thank you, everyone. With that, we'll adjourn. Thank you, Tom. Great lecture. Great